Hi, welcome everyone. Welcome to the session here on primary care. We have a super exciting, diverse set of speakers representing all continents of the world. My name is Katrina Haug. I'm a reader in health economics from Imperial College London and chairing this session. So we will have 8 minutes presentations for each speaker, followed by the opportunity to the audience to ask very quick questions of clarification. And otherwise, we leave time at the end for an extended discussion. You may also, and that would be actually extremely helpful, to post your questions in the chat so that I can moderate this a bit. So Anna Verbeck is our first speaker. Anna, the floor is yours.
Thank you very much. Okay, I think you can see it now on full screen. So yeah, thanks very much for having me. I'm happy to present our paper, Equal Access to Primary Care, a benchmark for spatial allocation, which is joint work with Alexander Hering and Matthias Käding. And I want to start by, oh no, it's not. I want to start by jumping right into the paper and give a brief overview of the full paper. So we try to answer the question, what is the amount and regional allocation of PCPs in Germany to generate equal access to primary care? And we also, in the full paper, look at common characteristics of regions that experience a shortage of PCPs, but I won't focus on this question in the presentation. So we tackle those questions by using a greedy algorithm that we modify. So we take the limited capacity of PCPs into account because they can just cover a limited demand of patient visits. And then we compare the outcome to the status quo. And our first results show that or suggest that we should have been needing 6% more PCPs in Germany in 2019 to generate this equal access to primary care. And for now, we see that besides reality, which is probably the main focus, especially in Germany, that also business tax and migration index correlate with a shortage of PCPs. So why do we care about this issue actually? So uneven geographic distribution is something that is widely discussed in many OECD countries, and mostly focused on rural versus urban areas. But we can see, for example, in Germany that the physician density cannot only be explained by the population density. So in this scatter plot, you can see, for example, if we focus on Germany, that the city-states Berlin, Hamburg, and Bremen have a very high physician density, but also federal states like Saarland and Bavaria, which have large rural parts, also have a physician density that is above the mean. I started with Germany as an example, and so we focus on this. The German setting is quite suited because equal access to healthcare is manifested in the Sozialgesetzbuch, so the Code of Social Law, but it is also, or it should also be cost effective. So you cannot just flood the whole country with PCPs and everyone has access. Also, there's a legal note that each resident should have access to at least one PCP within 15 minutes driving time. And we also use survey data of the National Association of the Physicians that found out that PCPs have a limited capacity of 13,000 patient visits per year. To answer our question, we use different data sources. For one, we use the RWI GeoGrid data for demographics. They are on 1 square kilometer grid level. And with that, we want to look at the current amount and allocation of potential patients. We also use OpenStreetMap to derive the driving times from patients or potential patients to the PCPs. We use physician entries of online search engines of those associations of physicians to look at the current amount and allocation of PCPs, like in the status quo. And then we also use survey data from German residents to know about the current demand for PCP visits. We have information of the number of doctor visits per year, and we also have information on age. So on average, they are 49 years old in our sample and slightly more females. So we can use this for our algorithm. Yeah, but then coming to our first and foremost question, what is the amount and allocation of PCPs needed to generate the equal access to primary care? We use this algorithmic approach because, in this large problem size, the optimal solution would not be feasible, actually. This greedy approximation is close to optimal. And we modify it by taking the finite amount of visits of PCPs into account. And now I want to give a brief overview on what the algorithm is actually doing. So we start with a green field. So we have Germany with its residents by age and gender. And so we also know by age and gender their demand for PCP visits. But we do not have any PCP located in Germany at that point. And then, because I said before, we have this grid level data around each of those grid cells. We have a set with a different amount of grid cells. To each one, you have 15 minutes driving time. So we take this legal note of 15 minutes driving time from patients to physicians into account. And because we take street structure and topography into account, they look very differently. So each of those examples shows the grid cell in the middle. This is the dark blue shaded one, and every cell that is depicted here can be reached from the middle of the set in 15 minutes driving time. And then the algorithm goes like this, that it searches for the set with most uncovered demand for PCP visits and places a PCP in the middle of the set such that this PCP covers exactly the 13,000 patient visits. And then the algorithm continues with the next set, or maybe it's the same with most uncovered demand, and continues to do so until the PCPs are located in a way that there's no PCP with free capacity. So every PCP that is located at that point covers exactly those 13,000 patient visits. And then, of course, we are left with some unmet demand. And then the greedy continues to place PCPs in those sets which are not fully covered until all demand is covered. And then we are left with this. So we have 58,144 PCPs located in Germany. And then we compare it to the status quo. And you can see that we have those 3,000 PCPs more. So it's the 6%. And you see that it's much more equally distributed. So for example, in the city states, but also in the rural area, but also in other federal states, you have more PCPs, for example, where you had less before. So I'm very happy for your comments and discussions. If you have any questions, I'm happy to get them.
Perfect. Thank you so much, Hannah. If you would please stop sharing your screen. Are there any questions of basic understanding or clarification for Anna Verbeck? Fine. Then please welcome our next speaker, which is Joanna Pestana. Joanna, if you, we have one question from Ricarda Milstein. Ricarda, you want to just ask your question?
Yeah, thanks a lot. And I'm curious about the demand, the ZEP demand. Is this the number of visits that were realized, or is this the number of visits that people would have liked to have?
This is the question is, how many visits to the doctor did you have in the last 12 months?
Okay.
So I mean, it's survey data, so you do not really know what they say. Yeah, that's the setback, but Thanks.
Thanks, Ricarda. If you could please lower your hand afterwards, that I don't get confused whether you have a second question. Thank you. Then let's move on to Joanna Pestana, please.
Yes. You should be able to see my screen now and to listen to me. Perfect. So my name is Joanna Pestana, and I'm here to present this joint work with my supervisor, Professor Pedro Pita Barros. Here we want to measure the impact of the previous economic crisis on the quality of primary care provided in Portugal. And I want to emphasize this is a work in progress, so I feel very thankful for your comments and suggestions. So many authors have addressed the health effects on the financial crisis in European countries, particularly those most affected by the crisis. Few studies, though, have looked at the impact on quality of care, and in particular in primary care. And this topic is especially positively relevant today since COVID-19 outbreak overburdened primary care services with the conversion to telemedicine and managing of vaccines, particularly in Portugal. Plus the rising unemployment coupled with delayed healthcare services might prolong the health system shocks in the future. So briefly on the impact of the shocks in the health system, one can say that worse health conditions caused by a downturn are expected to increase demand for the healthcare services through the Grossman model. We can also think that we have an income insecurity where force families to decrease demand for healthcare services like preventive care. At the same time, we see public spending cuts, that is investment, which can restrict healthcare providers to adapt and then in the supply side. So these adjustment variables here, we can think about quality. So excess demand could be satisfied by sacrificing quality or prescription. So shorter visits compensated by more prescription, though less income could still limit the extent. So again, we don't know exactly the direction of the effect here. To study this, looking at the Portuguese case due to the scale and duration of the crisis makes completely sense. And I provide you some of the measures implemented, the policies implemented in the PDF. Our objective here is to look at the impact or whether there was an effect from the economic crisis on the quality of primary care, utilization expenses. And we also want to explore differential effects according to the type of organization of the units. We expect that to find a smaller effect for patients in family health units. These are special team-based practices with more autonomy and performance incentives, which were implemented in Portugal in 2006, and they cover approximately 60% of the population today. We do so by exploiting administrative data from all primary care units from 2010-2018, and we use municipality and employment as a proxy for general economic conditions in those regions. So as you can see, the crisis struck Portugal during the sovereign debt crisis, 2011-2014, and the effect was not symmetric across all regions. The outcomes we used here are the typical process quality indicators, and they have been slightly increasing over time. We also look at utilization of general practitioner visits and family planning visits, and we have average expenses on drugs and ancillary tests, and we look at the share of generic drug expenditure. Our empirical strategy, we estimate fixed effects model on all the indicators using unemployment rate. We expand this analysis by including also the dynamic panel model because this clinical performance and utilization on a given year can be related with levels from the prior year. So to account for this dynamic adjustment, we use lags on the indicators, and we also use two models, the Arellano bond with fixed first difference transformation and the system GMM with orthogonal transformation to preserve a larger sample. On the differential effect of the different types of organization, we use interaction terms and dummies for the type of practice. So now quickly to the results. In our dynamic model, we don't observe a significant impact on the local unemployment rate in any quality indicator, exception being set to the increase in the unemployment associated with 1.7 percentage point decrease in the rate of newborns with 1 hour visits to the physician until the 28th day of life. This can be due to potential low birth rate in these areas affected by the crisis and thus changing the denominator strongly and affecting the coefficient. We can also think about some kind of physicians in this area divert attention from babies into patients with more incidence like mental health conditions or chronic conditions. Some indicators that appear significant, they didn't pass the Sargent test on the validity of the instruments, and so they were not considered for our analysis. Now, if there was no impact on quality through duration in the local conditions, economic conditions, we can see what happened to utilization and if demand increased. And here we also observe for all the models that there was no impact on demand related to the rise in unemployment. And this is consistent with prior work, which was concerned with an increase in the use of fees that occurred during the austerity program, and which was then countervailed successfully by the increase in exemptions to the most deprived, that's guaranteeing access to the most deprived population. Finally, we also look at the expenditures, and here we see a significant drop in the average expenses for drugs prescribed and the share of generic drugs. But these coefficients can be capturing a purely mechanical effect, so we can think about physicians in the more deprived areas prescribing more generics, so this will make the average expenditure drop compared to the other areas. Simultaneously, if the drop in generic drugs can be due to simply adjustment, so if the generic drugs prices drops a lot, we will see the share expenditures dropping. We can't do much about it because we don't have information on the amounts prescribed, only on average expenditure per patient, and so this can lead us to these results. So let me wrap up. We found no strong evidence on the lower quality of care associated with the crisis. So economists tend to look here for significant effects, and this is not the case, but it's still a positive take on the efficiency of the policy which were implemented and the resilience of the sector. And the changes in the observed drug expenses are likely to be due to the strong generic substitution in the deprived areas and can be affected also by the drop in generic drugs. I must also say that during this period there was a strong reform in the pharmaceutical market, which was reported by the Memorandum of Understanding with the Troika. So despite the austerity measures, we can also see that access or utilization was guaranteed. And regarding the heterogeneous effects, I didn't show the results, but what we found was a weak negative association on the non-family health units. And this happened for the indicators on newborns, early diagnosis, diabetic patients with hemoglobin A1C tests, and hypertensive patient BMI records. So the family health units presented no significant results. So they appear to be more resilient to the shocks and affecting those areas.
1 minute.
Yeah, so there are some limitations on this paper, and also still some challenges we want to address. So first of all, it's really hard to disentangle the supply and demand effects, since both austerity measures and the crisis occurred simultaneously. And also we might suffer from a middle variable bias and heterogeneous effects models, because family health units was a voluntary scheme, and this might introduce some upward bias on our results. Having said that, I would like to thank you for your attention, for the financing I received, and I'm available for your questions and comments now.
Many thanks, Joanna. Any questions or clarifications to Joanna? I don't see any hands. Oh, I see one hand.
Or a clap.
Julius, no. Are you clapping or asking?
Both. First of all, clapping. It's a shame you can't do clapping, really. Maybe we should all unmute us and clap. Thank you very much. I just have a question. Is my understanding correct that the data that you're using is all data after the crisis happened? So there's no data to before the crisis happened. So there's no comparison of what the levels were before. Is that correct?
Well, yes. So the crisis in the sense of the European crisis or of the global crisis started in 2009, but in fact in Portugal it started more in 2011, as you could see by the unemployment rate. But indeed, my data started in 2010, so I have 1 year, so to say, prior to the adjustment program. Yeah. Okay.
Is it? I mean, I presume you've looked in this already, but is it difficult maybe to expand the panel before the crisis further, because make a lovely analysis for different diff to really get existing potential trends out of this estimation?
Yes, so I must say that also the adjustment program and the reforms from the Troika also implemented a strong reform on the registries. So this data before was not in any quality or available. So I must say, DIF would also work to measure recovery. I thought about doing that. So just seeing what happened in the recovery, not outside of the crisis, because indeed there's no hope of having good quality data before the crisis in the primary care in Portugal.
All right, so is my understanding correct? You used the diff and diff. Did you find anything different then, even though it's 1 year you said before, I think?
No, I didn't use diff and diff. I just used fixed effects and dynamic model here. Mm-hmm.
Okay. Thank you. Just wondering.
Thank you very much.
No worries. Thank you.
Great, thank you. We have now our next presenter. Before I invite you to share, Igna Bronfer, I just wanted to find out whether our fourth presenter has shown up, which is Tina Rampino, maybe hiding under a different name. If you could please tell me whether you have arrived. No, okay. Let's hope for the best then. So Igna Bronfer is our next presenter. Igna, if you would please share your screen.
Thank you very much, Katerina. Good day, everyone. Happy to be in this session and to share ongoing work about understanding the sources of inequality in the quality of maternal care in India. Now, this is joint work with Leander Buisman and Professor Eddie van Doorselaar. So, unfortunately, maternal deaths are still at a very high rate in India. 20% of all maternal and infant deaths worldwide occur in India, and in other words, there is one mother dying every 5 minutes from some kind of complication related to delivery or the prenatal conditions. Now, we know from earlier research that in some lower middle income countries, the quality of care can be lower than expected. Now, less is known about whether there are socioeconomic inequalities in this lowered quality of antenatal care, and we're looking specifically at India. So we set out to measure socioeconomic inequality in the self-reported quality of antenatal care and try to differentiate between inequality within villages and inequality across villages. Now, to identify the quality of the antenatal care provided, we used the demographic and health surveys where women were asked whether the following actions took place during their antenatal care. So you can see here, these are sort of quite basic measures of quality, and they align with requirements that the WHO has set out for good quality antenatal care. Now, women are asked to report on these measures for the most recent live birth that took place in the 5 years previous to the survey. So it's important to realize that obviously there is going to be some bias here in these self-reports, because it could very well be the case that some women, maybe those from a lower socioeconomic group, are less likely to be able to exactly identify whether they indeed received these different elements of antenatal care. Now, in line with other literature on self-reported quality of care, all elements here are weighted equally, and when we add them up, that results in a quality index ranging from 0 to 7. 0 when the mother reported to have received none of these 7 items, and 7 when she reported to have received all of them at least once during the entire period before she gave birth to her most recent live child. Now, we use data from 2005 and 2015. The Indian DHS is not yet available for 2020. And we can see that sample sizes are relatively large. And what's especially interesting to see is that the sample size in 2015 is considerably larger than in 2005. Now, the parties involved in collecting those data indicated that in 2015, they really covered all states of India, while in 2005, not all states were included in the DHS. We used the primary sampling units, so that were used when identifying who should be interviewed as part of this survey, and we only included births resulting from primary sampling units with at least 10 reported live births. We then assume that everyone in the same PSU is from the same village, and we even go as far as to assume that it's likely that those women used care in the same healthcare facility. Now, as I mentioned, this is ongoing work, and this is still sort of a point of debate. So we are currently trying to figure out whether this assumption that those living in the same village also use the same healthcare facility is on average correct. If not, we might decide to split our sample, differentiating between those who used services in a public versus a private facility in coming from that same PSU. Now, to identify socioeconomic status, we use the wealth index based on the principal components that are derived from reported household asset ownership. So this is kind of the standard way to go about generating a wealth index from the DHS data. But we then standardize this wealth index to have a standard deviation of 1. We do so to allow for easier interpretation of our coefficients. We estimate the ordinary least squares regression, and we then use the coefficient of this standardized wealth index to identify within and across village socioeconomic inequalities. Now, here are our results. Let me help you to go through these. So first, looking at 2005. We estimate our OLS models both without PSU fixed effect and with PSU fixed effect. And that is what allows us to identify within versus across PSU inequalities. Now, first, running this relatively basic regression where we do not include fixed effects for the PSUs, showing that the coefficient of the standardized wealth index is 0.15. It's relatively large and significant. And at this stage, we don't include any other controls. Now, the important move here is to this second model where we include PSU fixed effects. So what we see here is that the standardized wealth index coefficient is going down, and in fact, there is a 27% reduction between these two coefficients. Now, and in a bit, I will share how we interpret that 27% difference. For now, I'd just like to indicate that on top of this PSU fixed effect model, we also estimate 2 other models where we include respectively primary and secondary education, and then also control for age and marital status. Now, what you see here is that it doesn't really matter whether we include age and marital status so much, but the coefficient drops a little bit, but continues to be significant. So as I said, there is this 27% reduction, and given that we exclude any within village effects by introducing the PSU fixed effect, we now know that there was probably a 27% of the socioeconomic inequality is driven by differences across villages, while the large majority of this inequality, 73%, is driven by differences within village. So if we were to assume that mothers from the same village use care in the same facility, then this suggests that when seeing the same healthcare providers, those from a lower socioeconomic group receive considerably lower levels of quality of care. So poorer patients. receive lower levels of care. Now, obviously, I already mentioned to you that we are at this stage not yet completely sure whether we can claim that these are all differences within the same facility, but we do know that these are differences in women from different socioeconomic statuses living in the same PSU. Now then, the 2015 data, what we see there is that socioeconomic inequalities reduced all in all, so that's good news. And on top of that, we also see that a smaller share of the inequalities is driven by differences within villages. Again, our results are more or less robust to including further controls. So from this, we have our preliminary conclusion that socioeconomic inequality in quality of self-reported quality of antenatal care decreased considerably between 2005 and 2015, so that's positive. The socioeconomic inequality is largely driven by variation within the PSUs and much less by variation across facilities or across PSUs. This suggests that there's room for improvement in quality of antenatal care provided specifically to pregnant Indian women in the lower socioeconomic classes. Thank you very much for your attention.
Thank you, Igna. Are there any questions for clarification to Igna? No, I don't see any in the chat. Julius, are you clapping again, or is there a question again?
I have a question, actually. If no one else questions, I don't want to monopolize the questioning tool here. Thank you very much for this exciting presentation. I just wondered, do you use the wealth index as a continuous variable here? And if so, are you motivated maybe to break it down in different quartiles or quantiles to see how the effect actually changes to identify heterogeneities at different wealth levels?
Yes, thank you, Julius. Very good question, of course. Here we are looking at the continuous variable because that gives us sort of a more precise idea about inequalities in socioeconomic status. But I agree very much that we should add the different quintiles to sort of aid the interpretation and see whether there is maybe something going on that, let's say, the one before the bottom quintile is receiving lowest level of care, for example. So definitely take it into account.
It'd be interesting to see, yeah. Thank
you. Thank you. Then I wonder whether our last speaker has turned up meanwhile. Tina Rampino, are you somewhere hidden in our list of participants, maybe under a different name? No, so it looks like a no. So we have then quite a generous amount of time for discussion. So please just open your mic and ask the question directly or post it in the chat to all presenters now.
So I noticed that there is a question from Christiana. Or would you like to wait, Katarina?
No, that's great. Christiana,
okay.
Do you want to post your question? Do you want to ask your question directly?
I was just wondering about, because the inequality decreased a lot, like, at least it appears from the results. I was wondering about the level of the quality index. Could you say something about, was an increase, a decrease, did it stay constant?
Yeah, thank you very much, Christiana. So I don't know the numbers from the top of my head, but there was also an increase in average levels of quality of care between 2005 and 2015. I think it was about sort of 1/3 increase in this range from 0 to 7.
Okay, thank you.
Thank you. There is a question posted in the chat by Ricarda Milstein. Ricarda, do you want to ask your question or questions to Anna?
Sure, thanks a lot, Anna. First, Thank you. Thanks a lot for your presentation. I love that you introduced caps on physician time. I haven't seen this so far. I think that's a great idea. I'm a bit concerned that your model caters supply-induced demand, and I'm wondering whether you've also explored, for example, the mobility-based adjustment from the Bedarfsplanungslinie or planning guideline that we have. For example, I expected your decision tree to be a bit more extreme, and you might simply cater to those in urban areas, a bit younger, very health sensitive. I was wondering how you want to counteract to that. And I also liked that you added a bit more substance to areas beyond an urban-rural identification, and that you already did some work on ranking the attractiveness of an area based on childhood education facilities, etc. I was wondering whether you've looked at that as well. Thanks.
Yeah, so to your first question, so no, we didn't use this mobility-based information because for now, I think the problem is that we have to get it matched to the information that we have on this grid level. And so this was a problem so far, and I don't know if we can manage to get this into account, but yeah, of course it is an issue, and I think we thought about a lot about this supply-induced demand. But for us, it was that because we used this survey data from the whole country, we thought that it might be that on average we get it right, but because we just look at the whole country, but yeah, it's probably an issue, and we should do more effort or put more effort into that. Yeah, but thanks a lot for this attractiveness measure, and those I think we were just like looking for more information, and it's just like work in progress. So we look for things that we can get, and I think that is something that we work on a lot right now. So yeah, thanks very much.
Joanna, you have your hand up. Do you have a question?
I do, but I can wait if there's more on the chat.
Fine. Ask your question.
Okay, so I have a question for Anna and for Irma, but I might start with Anna because I was just now speaking. I come from a bit different perspective, and I think about this issues in Portugal from a physician shortage issue, and not much the case of physician-induced demand. But I was thinking about the skill mix, and if you thought about, so here, for instance, in areas where there is a lot of restriction or difficulties to hire a physician, they rely a lot on nurses taking this function. And if you look at other professionals providing care in these areas, which might suppress the demand, or I understand that on the gazettes, on the law, you have the physician, but if this could somehow be answering this demand.
Yeah, so for now, the thing is that for now, it's like very hard in Germany. I think we have some projects and some things that start right now where you also have like other professions who provide care and have also the opportunity to, I don't know, take blood or do those things. But for now, it's like they always have to check with the family doctor or with other physicians what can be done, what has to be done. But I think this is something that is a road that Germany is also on, because especially in rural areas, I think that's something, because there many PCPs have to get out to the patient, and so if you take others into the provision of care, that might be a help. But for now, we didn't take it into account because it's not possible for them. But thanks.
It's still very interesting.
We have a question from Aditya. Do you want to post your question or ask your question?
Okay, thank you. I would like to ask Joanna. We meet again, Joanna. Hi. I'm curious to know about the system in Portugal. So there are two types of health facilities, the family health units and the non-health family units. maybe I missed a little bit before. Can you elaborate a little on how these two types of health facilities differ in the context of how they reach the utilization performances? Which type of health facilities shows a better performances in the utilization, and what factors that that play a role in reaching those utilization performances? Thank you.
Thank you very much for the question. Yeah, I didn't go into detail on that because I am also still starting and on these projects and looking at aggregate effects and looking at the specific effects per type of practice is tricky because what I said, it's a voluntary scheme. So it's very difficult to know exactly what or to exclude selection here from the coefficients. But indeed, there is currently actually a tree model system. Since 2006, the physicians could get together and create this family of units. They are all civil servants, but they have more flexibility in saying, I want to work with this team. Still, they have, like the case of Germany, the limitation in terms of location where they can open their practices because there is, they cannot open everywhere. So the practices are still owned by the state. They're not owning their own practices as other countries do. In terms of utilization, the difference is, first of all, these family health units don't have out of these patients. So in suburban areas where you have lots of migrants coming from other regions, they have longer relationship with the patients because they have always the fixed list, and the other non-family health units are the ones which have to attend people which are migrating in the country. This, of course, has issues on utilization of the planned visits at least, and also, of course, on the performance results. Another issue, and what I can see on my data, is that these family health units have a great substitution between physicians. So I guess what you yesterday talked about horizontal referral, it's more possible within these clinics with more physicians because they are aware of their lists, and they can share with other professionals when they leave or go on maternity leave or when they are on vacations. As for the other practices, they don't have this, and they have mostly a population which is registered not with a fixed physician. Also to say that the family health units are pretty standardized units with 7 physicians more or less. As for the other non-family health units, it's a bit tricky. So they can have 1 physician and they can have lots of physicians. So it's a bit heterogeneous. And the idea of the reform was to, of course, implement the performance and bring performance gains and quality gains to Portugal, and also to convert all physicians to this type of models. But there is a cap, a yearly cap on the number that the state can allow, and not all physicians took this opportunity. So still there are many, after 13 years, we still have many of the non-family health unit type of practices. I hope this answered your question.
Thanks, Joanna. I think we have another question from Guy McIntyre.
Hi, thanks. I wanted to say that I really enjoyed all the presentations, so thank you very much for the presentations. I wanted to ask Igna just 1 or 2 questions. I'm intrigued to know how you're going to be able to work out whether the assumption that you know, everyone within the PSU is actually using the same provider, whether that assumption is correct. Are you engaging with colleagues in India who sort of, yeah, have some kind of knowledge of density of providers in these areas, etc. And the second question was that I'm not sure if you were able to join the opening centerpiece session and whether you've considered looking at issues that of intersectionality. Gita Sen sort of spoke quite a bit about the importance of looking not only at socioeconomic status, but within socioeconomic groups, at the issue of caste, say, for example, which is particularly important in India. Anyway, thanks very much.
Thank you very much for your comments and suggestions, Guy. So a project that's kind of preceding this one, but that's still ongoing, is a project in which we work together with a particle Together for Her. And Sumita Saharan is our contact there. She is an expert when it comes to research on antenatal care in India. And sort of without going to too much detail about that other project, which I believe is actually more exciting than this one using existing DHS data, she has made it very clear that usually the public and the private providers receive women from all different socioeconomic levels. So contrary to most other countries, private facilities are not only sort of dedicated to the higher socioeconomic groups. And building on that, but I'm very open to agreeing that there are limitations in this, we thought that we know for the women within each PSU whether they use their antenatal care at a public or a private provider. So by simply differentiating between those two, we think that we will be able to identify whether women went to the same provider. But of course, if they are going to a private provider, which is further away, or a public provider, then we will not be able with these data to pick that up. So that's clearly a shortcoming, but by differentiating between public and private, we can at least see whether women in the same PSU are going to different facilities. And in a first sort of very quick view at those data, I noticed that there are PSUs where basically no one is going to a public provider. So that at least suggests that there is not that differentiation between public and private providers being visited by those women. It could still be that they are not all going to the same private provider, but that they're going to different private providers. Now, there could be sort of a further step by looking into whether they report to have been to skilled or unskilled providers. But I noticed that even those women reporting to have used care at unskilled providers can then subsequently indicate that they actually received all those different quality elements that are indicated by the WHO. So that came as a surprise to me, to be honest. But maybe that's also a route to differentiate between different providers they've used. So that's the way we plan to go about it, but it's not ideal. And then when it comes to intersectionality, unfortunately, the DHS doesn't contain that much information on socioeconomic status, but we know something about level of education. So having heard your suggestion, I'm thinking that we could look into sort of differences across levels of education instead of purely looking at this wealth index based on household assets.
Thanks. Anna, you have a question?
Yeah, just a follow-up question on that, actually. So how do you know how many of those private facilities are in a village? So are there like a lot, or is it just like one or two, or?
So from the data, we don't know, because we don't have information about which specific facility they visited. So we can't even observe whether they are different ones and whether they are located close by or far away. But earlier research suggests that women using antenatal care often go to the nearest provider. Yeah, but again, that still doesn't answer your question. So I don't know how many facilities there are in each PSU.
All right, okay, thanks.
Joanna?
Yeah, I also have a question. Irma, you know, I don't know much about this literature, but I was listening to you and I was wondering, Did you, or was there a change in fertility rate from these 10 years or say in different groups of socioeconomic groups? I don't know what is in the wealth index and whether fertility rate is on a wealth index included.
That's a very good question. So what we actually noticed is that the number of births per PSU dropped quite considerably between 2005 and 2015. And then having contacted those who collected those data, that's actually also called the Indian Family and Health Survey, we learned that there was indeed a considerable drop in fertility, which we had already observed from the reports. But we initially thought that there was a change in the sampling. So we observed a large decrease in the number of births by PSU, and we thought that that was the case because not all women had been interviewed in each of these PSUs, or at least a smaller share than was the case in 2005. But from those who collected the data, we learned that was not the case. So there is a considerable decrease in the number of births that we observe. And I think that partly relates to a drop in fertility rate.
And can you know if it was different through the different socioeconomic groups?
So I haven't looked into that, but that's a good idea. So I can definitely look at average number of births by PSU across different socioeconomic groups comparing 2005 and 2015. Yeah, I'll do that.
Also, I don't know about religious groups and whether there was some difference or migrations, and this will be related to some kind of fertility rate issues, or if it's pretty homogeneous in India. I don't know about that.
Good point. A lot of migration going on, and I also think we wouldn't be able to sort of observe that in our data because it's not panel, right? It's cross-sectional, but definitely something I will also look into.
Right. Any other questions from the audience?
Can I ask a question to my fellow presenters?
Sure.
So Anna, I was wondering, so in your results you indicate that there is a 6% shortage of GPs, sort of compared to this ideal situation that you identify with your greedy algorithm. Now, just thinking about the Dutch situation, it's not the same figure, but I remember that recently there was a report indicating that 1/3 of all primary care practices or GP practices said that they had a shortage of GPs, a shortage of primary care providers. Now, that seems a way higher number than the 6% that you find for Germany. So I was wondering whether this means that there is really not so much of a problem in the number of primary care providers in Germany, or that you think that this 6% still suggests a problematic shortage?
Yeah, actually it's something that we thought it's worth reporting. So because there's at least some difference, but for us, it's also seemed that it's not like the largest difference between the numbers. So we thought it's more about how it is distributed, and that is actually the point of concern, and that is the point that we want to focus on. Yeah, actually in the paper, but we thought so I thought it's interesting to hear your ideas on the first approach, because this is actually where we base the rest of the paper on. So yeah, but indeed, yeah, if you compare it to the Netherlands, then it doesn't seem to be that large of a difference.
Yeah, and I mean, we have been lucky enough to be able to also transfer some of our intensive care patients recently to Germany. So it seems that when it comes to capacity, there is more capacity in Germany than there is in the Netherlands in the healthcare system.
Yeah, although that's of course a different, something different if you look at hospitals.
Completely different.
PCPs, yeah, but
True.
Yeah.
True. Yeah.
Thank you.
Yeah. And if that's allowed, I'd like to ask Joanna a question as well. Joanna, I was curious. So I also really enjoyed your presentation, just like I did with Anna's. And you look at the effects of the crisis and you then sort of proxy that crisis with this measure of unemployment, right? So I was wondering, so I don't know the Portuguese context, would you argue that indeed unemployment rate is representative of the extent of the financial crisis going on at different points in time? Or are there also other measures that might also sort of proxy this effect of the crisis?
That's a very good point, Irma, thank you. Indeed, employment rate is the most commonly used measure first. Second is the most available measure as well at the municipality level. So I tried to look at other indicators and looking, for instance, at purchasing power, for instance. But the issue is that we don't only have data every 2 years. For the municipality level. I'm also going to look at average income, but again, it's difficult to capture the crisis on average income. This was the easiest and measure to use. So this is the choice laid on that one for convenience as well.
Yeah, I mean, that's very understandable.
Yeah. I mean, I thought the same actually when I saw that, because there could be some kind of permanent or sustained unemployment in certain regions versus in other regions, which means that you have differences in socioeconomic characteristics across regions that are more permanent and than the crisis. But it's difficult really to, I agree, to find a way of disentangling this, right? This more permanent disadvantage.
Well, possibility was to look at heterogeneous effects. I don't know if you agree, if this would work, but I was thinking of using quintiles, for instance, of average income per region and trying to see cumulatively, on the one hand, which income quintile the area is and change in unemployment that occurred there, and whether we would find some kind of gradient.
Yeah, maybe some more long-standing measures of socioeconomic deprivation, such as potentially educational attainment or things like that. I know also that both Anna and Igna were keen on getting comments from all the clever colleagues in the audience on the methods that they chose. So Anna choosing the a machine learning technique, and Igna had specific questions, I think, on the sampling unit that she used. I thought actually, Igna, did you, I mean, I think you say that you excluded the villages where there were less than 10 live births, right? I mean, do you have any statistics on how many villages or communities you actually exclude with that approach?
Yes, yeah, good question. So we looked at different cutoff points, and using this approach, we lose about 1/3 of all live births in our sample. We've also considered both looking at villages, including villages with, for example, only as little as 5 live births. That, I mean, means that we are including almost all observations in our sample, and we have tested our results for robustness, and our results are not heavily affected by the cutoff that we choose.
And did you find actually significant differences in stillbirths across villages? Because by focusing on live births, you may be biasing via the quality of antenatal care provided, the variable you're looking at.
Yes, we would love to, because it's obviously that's a very good point. We don't know much about stillbirths. So when women report to have given birth to a child that wasn't alive, or when they report to have had a child aborted, then no further questions are being asked about antenatal care utilization. So we know little about that, although sort of hearing your suggestion, we could at least identify number of stillbirths by socioeconomic status to get a feel for whether there are very large differences there, but we cannot attribute that difference to differences in quality.
Yeah, I see. But you know where the women lived, right? At least where the stillbirths.
Yeah.
So you could kind of see whether they're systematic or yeah, significant differences.
Yeah, that's a good idea. Yeah.
Great. Yes, I also had a question actually on Anna. Oh, actually, we are at the end of our time. I'm just realizing. So maybe I better stop and post my question to you afterwards. So thank you, all of you, for brilliant presentations and also a very lively and engaged discussion. And I hope to see you around this conference, but then hopefully also in real life in 2 years' time. Please don't forget to vote how you found this session, and I wish you a happy rest of your day. Bye.